Good morning once again, and I would like to thank once again to Professor Tinika and Batika to invited me to this excellent meeting, and really I'm also getting some information about the system of this area and what are the difficulties here. Perhaps I can mention to all my colleagues and the future collaboration I'm sure will help to this region. Coming up before giving this, starting this lecture, coming up the system in Turkey a little bit more, I would like to start with emergency, with ambulance system. But before that, I think to have ambulance system cannot solve the problem. You need, first of all, you need to increase the number of your centers in your center of excellency and center of any help in your country. Just having said that, I can say that in Turkey in last 10 years, in last even 15 years, the number of cardiac surgery centers has increased enormously. You may not believe in numbers that in Istanbul we have 83. It was 88. Now we have 83. 5 of them has closed in last 2 years. Open heart centers. Believe or not, Istanbul has 17 million population, and we have 83 active PCI plus open heart center. And in Izmir, we have 13. Last night, I have counted myself, 13 open heart and PCI center. We are 3.5 millions. And in Ankara, I couldn't count over 20 last night just to prepare this talk. Probably it's more than 20, but I have counted myself 20 active centers in Ankara. And I know by numbers that, by word of mouth, that in Turkey we have more than 380 open heart centers for 70 million. So if you have that many centers, then even taxi driver can take you to the for PCI to one of that centers. So you don't need always to have this ambulance system. Taxis are enough even. So just a joke, I'm saying that. So first of all, you have to have centers. And in Diyarbakır, perhaps you know about this city. It is one of the most southeast cities. We have one government training center and one university center and 3 private centers in Diyarbakır. And they are serving to Iraq now more than Iran. So I think the most important point is to have a widespread numbers of active cardiac surgery centers in the country. Then, of course, your ambulance system can bring the patients to you. Not to waste time much, I'll just add one point to the new improvement in our ambulance system. In Istanbul, although we have 83 centers, we have traffic jam as well. Therefore, we realize that we are losing patients in ambulance due to the traffic. So then we were aware of this thrombolytic therapy in ambulance. Therefore, it has started. But, you know, there has been a lot of mistakes in the ambulance. You can give, or the untrained person can give thrombolytic therapy to an aortic dissection case as well. So we had some misdiagnosed as well, but as soon as they get they think that they have to give thrombolytic therapy, they have to get in touch with the center that they are taking the patient to, and with the help of the consultancy of the cardiologist in the center they are taking the patient towards, they can only give, they are authorized to give the thrombolytic therapy in ambulance in last 1 year only. Before that, they were not allowed to give thrombolytic therapy in ambulance because of the danger, as you can guess, a lot. But this system has started as a pilot system in Istanbul, Ankara, and Izmir only, not at the rest of the country because of the danger of the system. And we know that in 2-3 hours, before 3 hours, they can reach any center in Turkey. I think this is enough about the information, and I can give a number, an additional number that I know by word, mouth of word. We have more than now, I think 1,500 cardiologists and in Turkey, and around 1,000 cardiac surgeons. So there is a little bit even overproduction of cardiologists and cardiac surgeons in Turkey, but the most important thing is manpower, as you know, trained manpower. So I think this is another issue, that you have to increase the number of active cardiologists and cardiac surgeons in your country. And we are ready in any kind of collaboration in terms of training in Turkey and in European Association of Cardiovascular Surgery. I can also make an announcement that in Izmir this year, in the beginning of August, we are arranging, and as European Society of Cardiovascular Surgery, we are arranging a course for how to write, it's a summer course, how to write a paper, scientific paper in Izmir. We will give an award, we will give sponsorship for 10 scholars. So you can apply for it if you follow our emails. If I am allowed, can I start my talk, and which is about surgical emergency? How long do you allow me? 15 minutes? 10 minutes. 10 minutes only? Okay. Then I have to skip some slides because it's for 20 minutes. And emergency surgical revascularization in MI is, oh, it's not working. Oh, okay, so now it worked. Is an important issue, but we must all know that guidelines on myocardial revascularization in 2010, which was arranged by ESC and EACTS, show that coronary bypass is indicated for class 1 indication in general for left main coronary. It may be not good for the cardiologist in the hall, and any proximal LAD and triple vessel disease, it's class 1 indication. And there are a lot of class 1A indication situation apart from 3 vessel disease for coronary bypass. So we must remember that interventional cardiology is not the end of the road. We also always have the coronary bypass strategy. But coming up, acute MI, it is a different story. Again, acute MI, even to start with angiography, is not always indicated. Patients at a very high ischemic risk, refractory angina with associated heart failure, arrhythmias, or hemodynamic instability should be considered for emergent coronary angiography under 2 hours. So it's class 2A indication. And also an invasive strategy should not be performed in patients at low overall risk, at a particular high risk for invasive diagnosis or intervention. It is class 3 indication. So even angiography is not always indicated in acute MI patients. According to ESC, EACTS guidelines, also in cases of unfavorable anatomy for PCI or PCI failure, emergency coronary bypass in evolving STEMI should only be considered when a very large myocardial area is in jeopardy and surgical revascularization can be completed before this area becomes necrotic, which is under 3 or 4 hours. Current evidence points to an invasive relationship between surgical mortality and time elapsed since STEMI. And when possible, in the absence of persistent pain or hemodynamic deterioration, a waiting period of 3 to 7 days appears to be the best compromise. Older age, and we know that impaired left ventricular function and comorbidity are associated with higher surgical risk. And there are a lot of CRTs, RCTs, clinical trials, randomized trials, shown higher rates of repeated revascularization procedures after PCI compared with CABG. So CABG is really favorable because of its less re-intervention after the operation. There are a lot of CRTs like ASAM, cardia trial, whatever. Whatever you can do by PCI or cardiology, as cardiologists, like you can give repeatedly regular stress tests, or you can give a very good diet, whatever you can do, or cut down beer or junk food, whatever you do. Even Bill Clinton had to go emergency coronary bypass. So he had, although he had followed very closely by a cardiologist. We know that, therefore, we as cardiac surgeon, we have to prepare ourselves to deal with this emergency coronary bypass, which has a little bit high risk, high mortality rate. For instance, blood cardioplegic solution with some substrate-enriched hyperosmotic and hypocalcemic stuff, as it was reported by Beiersdorf some years ago, can improve the results of coronary bypass and increase the postoperative segmental contractility due to can be reduced due to initial reperfusion injury, as you can see at this slide. Also, there are some other techniques like off-pump technique, but also, as Ludwig von Segeser has reported, you can use on-pump, but without cross-clamping technique, just to increase the perfusion rate. As you can see here, all low ejection fraction cases like 27% has increased 1 year later around 40 or 50% after the revascularization during acute MI with this technique. And also, there are a lot of techniques that can be used during the around MI, around the coronary, when you are performing coronary bypass during MI. Some medical support like aldosterone, beta blocker, ARBs, following and before and after MI, following coronary bypass, that may increase the inhibit left ventricular remodeling and increase the ventricular function after the coronary bypass. If you look at the AACC AHA guidelines for coronary bypass grafting during acute MI, indications are so clear. Emergency coronary bypass is recommended in patients with acute MI in whom one, primary PCI has failed or cannot be performed. Secondly, coronary anatomy is suitable for CABG, And third, persistent ischemia or significant area of myocardium at rest and or hemodynamic instability refractory to non-surgical therapy is present. So this is class 1 indication. Again, class 1 indication, emergency coronary bypass is recommended in patients undergoing surgical repair of a post-infarction mechanical complication of MI, such as VSD or mitral valve insufficiency because of papillary muscle infarction and rupture of free valve rupture. And the use of CABG is reasonable when multivessel disease, recurrent angina MI, in the first 48 hours of STEMI, just reasonable, and it's class 2A indication, and early revascularization with PCI or CABG is reasonable for selected patients over 75 years of age with ST segment elevation or left bundle branch block who are suitable for revascularization, irrespective of time interval from MI to onset of shock. CABG is recommended in patients with cardiogenic shock. Shock is another story, who are suitable for, this is class 1 indication. For CABG, now it is irrespective of time interval from MI and onset of shock and time of MI to CABG. Again, class 1 indication in patients with life-threatening ventricular arrhythmias believed to be ischemic in origin in the presence of left main stenosis over 50% or three-vessel disease. At this situation, we have to mention about cardiac arrest and resuscitation. Post-resuscitation patients can go to emergency coronary bypass. And cardiogenic shock, why? Cardiogenic shock is the leading cause of in-hospital death for MI patients. Optimal treatment demands early reperfusion as well as hemodynamic support to prevent end organ failure death. No time limit should be set between onset of symptoms and invasive diagnosis and revascularization. In these patients, complete revascularization has been recommended with PCI performed in all critical stenosis, large epicardial coronary bypass. Echocardiography, therefore, should be performed during the MI patients to assess left ventricular function and to rule out that life-threatening mechanical complications that may require surgery, such as acute MI, acute mitral regurgitation, secondary to papillary muscle rupture, VSD, free valve rupture, or cardiac tamponade. The natural history of these conditions, as you know, is characterized by 100% of mortality. The incidence of MI, post-MI VSD is 0.2 in 0.2%. Achieving an acute mitral regurgitation due to papillary muscle rupture usually results in acute pulmonary edema and should be treated immediately surgery. Whenever possible, preoperative coronary angiography is recommended. As you can see, coronary angiography is not always recommended when you have post-MI VSD. You have to directly go to VSD closure, and achieving complete revascularization, in addition to correcting the mechanical defect, improves the clinical outcome. Mechanically circulatory arrest assistance other than intra-aortic balloon pump can be offered at tertiary centers. Extracorporeal membrane oxygenator implementation should be considered for temporary support in patients with acute heart failure. And as you can see as a cardiac surgeon, ECMO can be performed at any cardiac surgery center by any cardiac surgeon. Here you can see that you can apply intra-aortic balloon and during and after reperfusion, and if it fails, the patient is still unstable, you can go ECMO. And after the ECMO, if everything goes well, you can wean. If not, you have to assess neurologically. If the neurologically patient is good, you have to go to LVAD or BiVAD therapy for bridge to transplantation or destination therapy, DT. But during after the intra-aortic balloon, if you can wean, you can go to standard therapy. And after the weaning, again, you can go directly without ECMO, you can go to LVAD or BiVAD. I have mentioned all about this. So, for cardiologists, we know that there are some percutaneous assist devices like tandem heart and Impella. These are percutaneous centrifugal pumps or microaxial pumps, but we all know that all RCTs show that no difference in 30-day mortality. Although there is a good result at the very early postoperative period, because of the adverse events such as bleeding and vascular complication in the group of percutaneous assist devices, we had some disappointing results. So cardiologists needs to work on this field a little bit more. As I mentioned, for resuscitated patients due to arrhythmias, CABG is recommended as class 1 indication, and CABG should not be performed in patients with ventricular tachycardia with scar and no evidence of ischemia. Another indication is emergency coronary after failed PCI. Failed PCI is a large area, and it can be, let's skip this. Emergency CABG can be considered after failed PCI for hemodynamic compromise in patients with previous sternotomy, should not be performed after failed PCI in the absence of ischemia or threatened occlusion, and should not be performed after failed PCI if revascularization is impossible. So it's not always a rule because of target anatomy, no reflow status. And CABG is reasonable after failed PCI for retrieval of foreign body when fractured guide wire or stent. So this is not a failed PCI, a failed operator actually. And coronary bypass can be beneficial after failed PCI for hemodynamic compromise in patients with impairment of coagulation system without a previous sternotomy. There are two not to be performed situation in patients with persistent angina with a small area of viable myocardium. There will be no benefit, and should not be performed in patients with no reflow, as I mentioned. Which bypass? Of course, Lima is recommended, and double IMA is much more recommended, but Lima must not be used for right coronary artery with less than critical stenosis because of the competition. It doesn't work, and let's skip all this. There are a lot of in women, women had an increased risk of failure of PTCA and markedly higher operative mortality after emergency coronary bypass. So in women, we must be careful, and we must send them, we must evaluate them, assess them before they are having an emergency. So women must go to cardiologists more often before they have an emergency or acute MI. And there are a lot of success stories in, as we can see from Japan, acute MI complicated by cardiogenic shock, and there is a list of papers who were successfully operated and had successful coronary bypass. In conclusion, coronary bypass during MI has limited indications, and failed or unsuccessful PCI or PCI complications are indicated for coronary bypass during acute MI. Mechanical complications of MI are very much important, and elapsed time limit claimed for PCI, like 3-4 hours, is also accurate for coronary bypass, and coronary bypass must be performed not later than 4 hours after the onset of symptoms, when possible, in the absence of persistent pain or hemodynamic deterioration. A waiting period of 7 days appears to be the best compromise according to cardiac enzyme levels. Thank you very much for your attention.